Hello, everybody, and happy Thursday night live. If you're watching this live, you are an Airway Circle member, so thank you for your support, allowing us to bring these for everyone. If you're watching this on a Thursday, we would love for you guys to also join us on our special Fridays that we have. Today, we have a very special doctor with us, introducing Dr. Jennifer Stafford, a dentist in Fort Atkinson, Wisconsin, where she owns and operates 3 practices focused on general dentistry, TOTS, myofunctional therapy, and TMD, sleep-related breathing disorders, and neuromuscular orthodontics. What do you not do?
It sounds like a lot, yes.
Amazing. She holds Mastership and Fellowship status in the International College of Craniomandibular Orthopedics, Fellowship in the Academy of General Dentistry, and is a Breathe Institute ambassador and certified VIVOS provider. In 2025, Dr. Stafford earned her master's degree in neuromuscular orthodontics from University of Jaume in Spain and co-founded Neuromuscular Orthodontic Studies. Passionate about airway health and chronic orofacial pain, she's committed to advancing collaboration and innovation to improve patient outcomes. Today's topic is Breathe Better, Stand Taller, the link between airway health and forward head posture. So super excited about this topic. Welcome to the Airway Circle stage. Would you like to say hello to everybody? Did I miss anything? Tell us a little bit about yourself.
No, hello. I'm so honored to be here. Thank you so much. It's amazing to have a group of individuals that are like-minded, especially in this area of airway dentistry and craniofacial health, where sometimes we can feel a little bit alone because it is going against I think what the norm is. And so it's awesome that you have built this group. A little bit about myself. You said all those big words and all the things that I do. And truly, it started with my own oral facial pain journey. So interestingly, I was watching one of the TNLs by Roger Price, and he said something that just really I identified with. And it's if you're passionate about something, it's not work. And you just really can dig in and it is who you are and it's what you love. And I would say that is what I am all about. I started in this journey 17 years ago, right outside of dental school. I had been a chronic pain patient since my early 20s, had found no help, had TMD, had airway issues. And I was super blessed to have the opportunity to learn orthodontics at a really young age, right out of dental school. And I went into that just thinking, hey, I'll learn another service. This is great. And when I started learning, I realized that the person I was learning from, Jay Gerber, also was very versed in TMD and airway health. And it was about expansion orthodontics and functional appliances and healthy airways. And I connected the dots that I had received the opposite for bicuspid extraction and retraction. And so in that, I had asked him to treat me, and he did, and I was pain-free for the first time in 6 years. And so it changed my life, right? So that's where I found my passion, and that became what I needed to do. So I just dug in. And so
Amazing.
I treat everything because what I
Yay.
quickly learned is that I can't do orthodontics if I don't know where I'm putting the jaw. And I can't treat TMJ and TMD if I don't know about airway. They coexist, right? And I can't know about airway and not treat tethered neural tissues because, right?
It just keeps going.
It's Pandora's box, right? So, and what's the link for everything? It's tethered neural tissues, right? Like that's really what starts the trajectory of all of these other conditions. And so that's what led me to where I'm at is I just kept asking questions. And interestingly, in doing that, it led me to multiple different opportunities. So I joined a group 10 years ago, International College of Craniomandibular Orthopedics, ICCMO for short. And I found other dentists that did the same thing I did and were passionate and wanted to help their patients. And so weirdly enough, I just got really involved in that organization. So all those like accolades are just from me finding a group I loved. And in that, and in connecting those dots, all of a sudden I started asking like the why, not the how. Because like dentistry, we're really good at the how. We're
Mm-hmm.
really good at saying, here's a protocol and here's the step-by-step process we can fix this.
Yeah.
We don't always look to the literature and the science to say, why am I doing what I'm doing, right? So I
Mm-hmm.
started digging again, and that landed me into this master's program out of Spain because I wanted to know the why. So here we go again, right?
Yeah.
And that's what leads to my talk today, because through that master's program, I started to learn to do my own research and
Wow.
publish. And I started to be able to answer those questions as to why. So when we get into the topic today about the link between airway and posture, we're really going to dig into why are the two connected, right?
Mm-hmm.
And how do we evaluate? And how can we make sure that pre-treatment and post-treatment, we can prove we got improvements with the patients. We can document it, right? Because we know symptoms are better and we know
Yes.
our patients are happier and feeling better. But how can we look at the diagnostics to say, here are the metrics that make us be able to stand up in court and say, it is better, right? And so
Exactly. Ah,
hopefully, yeah, hopefully after the talk today,
promo.
we have things that the dentists and myofunctional therapists can take with them
Mm-hmm.
and use right away on Monday to start documenting treatment success. That would be my goal.
That's amazing. Let's start.
All right.
I'm gonna record some of this. I'll be posting in our other groups.
Perfect. All right, we'll
I'm gonna
share my
share.
screen here. All right, so we got breathe better, stand taller. So again, we're just really going to talk about that connection between forward head posture um, and airway, and that it is so interconnected. And so, why is this topic so important? So we already talked about all this. We'll skip all of this here. So the growing posture problem, I think so much of the time we hear that forward head posture is really because of our lifestyle right now. We hear, oh, I have this kind of hunched forward posture because I'm on my computer all day. I just need to learn to straighten up. We see all of these modalities out there that are used to treat that compensation. But what we really need to do is dig into the root cause, right? And it is a really big problem. We know that 80% of individuals with diagnosed obstructive sleep apnea also have forward head posture. I think that percentage probably is low. I think that there's probably quite a bit more with diagnosed sleep apnea that have forward head posture, but that's the number. 66% of the population have a forward head posture compensation. Again, I think that percentage is probably low right there. One of the things that's really interesting is that when we have forward head posture, it really impacts the way that we breathe and function. And so we'll go into that on the next page. But what I think is really important is if we're going to address forward head posture, we need to address it at the root cause of the problem, not just focus our efforts on fixing the compensation. So some interesting facts about forward head posture and why it impacts our health. For every inch forward our head is from our center of gravity, we add about 10 pounds to our cervical spine. So if you think about a bowling ball and you've got that bowling ball, it's about 10 pounds and it's sitting at your center of gravity, you can hold that bowling ball for a long time. Every inch forward, you start to take that bowling ball, we're going to have a lot of stress and we're going to have muscle compensations. That chronic strain can lead to myofacial pain syndromes, headache syndromes, tension type headache. It just adds a lot of stress. The other thing that's really interesting is what happens to our breathing with forward head posture. So when our head posture is forward, it puts a lot of pressure on our scalene muscles and our SCMs, sternocleidomastoid. And so when we breathe in, if those muscles are really tight, we only have the ability to take that breath in and breathe through our chest in our rib cage versus diaphragmatic breathing. So there's that statistic that we have 30% less inspiratory force, and that's because of the way the anatomy is working. And then we also talked about the correlation between forward head posture and sleep disordered breathing. And the other thing we'll go over as well is the association between forward head posture and TMD. And all of this exists because of the anatomy. And so we'll go over that in the next slide. One of the things that we want to understand is why that forward head posture compensation occurs. So when we have low tongue posture, as we are all versed in, that can restrict the pharyngeal airway. So when we have a restriction of the pharyngeal airway, our primary need is to breathe, right? And so we do that by bringing our head forward. And when we bring our head forward, our airway gets bigger, right? So we're going to get a little bit clear here on terms. So bringing our head forward is termed extension of the cervical spine. Bringing our head backwards, so more the military neck, that's called flexion. So when we extend forward, we make the airway bigger. When we flex backwards, we make the airway smaller. So that compensatory extension forward opens up that airway space, but now our muscles have to adapt. And this occurs at a very young age, right? So as the muscles adapt, because of the way the anatomy is connected, we end up with TMD symptoms, and we end up with all of the musculoskeletal issues as well. So understanding the anatomy, super important. There's really three pieces to understand here. The first one is that the structures of the cervical complex are really unique. And so it's because of this uniqueness that we end up being able to compensate in the first place. It's really amazing that our bodies have this ability to compensate and make our airway bigger, and we can do this for such a long period of time. That's why the breakdown is so slow. The way that the muscles work, where they originate and the way they insert, that is what will cause issues with change in occlusion and the mandible. And then we have fascial connections, which we are all very versed in when we're talking about tethered oral tissues. So as far as uniqueness of the anatomy, it's that CCJ, craniocervical junction, that really provides a lot of mobility. So the CCJ it consists of C1, which is the atlas, C2, which is the axis, and then the base of the skull. And so the CCJ is there to allow for a ton of mobility, so we can move our neck in all different directions, and it allows for a lot of stability. So it supports the head weight without compromising the spinal cord and brainstem. It's super amazing. So these are all great things, but it's this ability to compensate that allows us to eventually succumb to chronic strain injuries over time. And it's why that happens so slowly. The other thing that's really, really unique about the anatomy is this hyoid bone. So the hyoid bone is the connection between the cervical spine and the mandible. And it's this free-floating bone. It has no bony articulations, which is really crazy to think about. It floats between the mandible and the thyroid cartilage. And it is that link between craniocervical posture and craniomandibular posture. And we have all of these muscle connections on that hyoid bone. So the hyoid bone sits right here. We have the mandible here. And it is the suprahyoid muscles that cause the mandibular change when we have that forward head posture. So the suprahyoid muscles, we have these digastric muscles. We have the mylohyoid muscle, we have the stylohyoid muscle, and then the one not pictured here is the geniohyoid muscle. So when our head extends forward, those suprahyoid muscles become really tight. And when those muscles become really tight, it brings our mandible posterior, okay? So when we talk about TMJ or TMD, the biggest thing occurring is that that condyle goes posterior and superior into the fossa, right? Why is that condyle going posterior and superior? It's because those suprahyoid muscles many times are so tight. And so when it goes posterior and superior, it can bring us off of that disc. So we have several compensations, right? We have the airway being obstructed. The head extends forward. When the head extends forward, our airway opens up. That's beautiful. That's amazing. But our mandible then is brought posteriorly. And all this occurs at a really young age, right? And then our body just starts to adapt and compensate for this. So the other connection and the other role is with fascia, and we're all really versed in fascia. Those of us who treat tethered oral tissues know a lot about this. So it's not just the bony anatomy and the muscle anatomy that is important in this interaction. It's also the role of the fascia. So as we know, fascia is the fibrous network that sits over the tops of the muscles. There's no breaks in it from the tip of our tongue all the way to our toes, right? And so it's really incredible. There's a lot of work now going and a lot of research going into this area of fascia. That fascia has memory. We can have injuries to the fascia, but any restriction to the fascia at any point in the system can cause compensations elsewhere. So the tongue is no different. If we have a restriction underneath the tongue in the lingual frenum area, that can also cause tightness in through the suprahyoid muscles. And if the suprahyoid muscles are tight, that can also lead to a forward head posture. So forward head posture, can start due to airway. It can also start due to, restriction of the frenum, or even situations where we have fairly good range of motion, right? We don't have a tongue tie in the traditional sense of the skin being tied, but that fascia can be really tight. And so when we elevate the tongue, it can pull on the suprahyoid muscles, also bring our head forward. So fascia impact, one of the things that was really interesting with the research that I did is learning what the frenum actually is, right? We know that it's fascia, and I always thought that there was a central area of fascia underneath the tongue in the lingual frenum, and that's what we were releasing. And what I learned is that actually the fascia underneath the tongue is this basket weave. There's not one central cord that's tight. And so that basket weave can get bound up at any point in time. And when we raise our tongue up to our palate, that basket weave of fascia kind of comes together and forms this central fold and can be really, really tight. So I thought that that was really interesting. So we'll get into assessment tools in a little bit here. So one of the things that we need to answer is, how do we accurately assess airway? So if we're going to look at forward head posture and we're going to look at airway and we want to see if the airway improves as we treat our patients and we want to see any changes in forward head posture, we have to have evaluation methods. We have to make sure those are accurate. And so really easily in our practices, we have technology with CBCT to evaluate airway volume, minimal cross-section airway. And it's really easy for us to see a patient. We get that CBCT up on the screen. We click the AI tools in there to measure the airway, and we say, okay, your airway is starting out at this volume. So let's go through treatment, whatever treatment may be, myofunctional therapy, frenectomy. In my practice, I do a lot with repositioning the jaw joint into a correct position. And then we get to post-treatment. We take that x-ray and we say, okay, let's take a look. We know our patient's symptoms are improving and we see no change in that volume of minimal cross-section area, or we see it actually gets worse. And so that was happening in my practice. I'm like, what is occurring here? Why am I seeing this, right? And so it's important to remember that the CBCT is a snapshot in time. And the posture we have going into the machine will really impact our accuracy. So one of the things we want to make sure of is that when we take the CBCT images, those taking the images are having that person in NHP or natural head position, okay? We want to make sure that that patient takes a deep breath, gets in their natural posture, and walks towards the machine, and we capture that image in their natural position. We don't want them to be forced upright or forced forward. This study by Dr. Zaghi and other authors shows that extension of the head or flexion of the head greatly changes that airway volume. So these are patients same day. One image is taken with the head extended forward. One image is taken with the head flexed backwards. And you can see one airway looks really great and open and the other looks really, really small, okay? And that has to do with head position. So our CBCT is really only accurate in evaluating airway if we capture the image properly. And that's really, really important. It's also important to note then that if we treat our patients and their posture naturally improves, it's that naturally improved posture that we capture the second image at. So if airway either gets smaller or doesn't change at all, it doesn't mean we don't have improvement for that patient. And that was what bothered me and why I looked at other evaluation methods and really dug into the research study that we're going to be talking about, because I wanted to be able to show my patient diagnostic success, not just have them feel success. I wanted them to be able to see success. Okay. So how do we objectively assess treatment outcomes with CBCT? It can be done, we just have to be careful, right? So it's important to remember the pharyngeal airway is a dynamic space. It's just one snapshot in time. Dr. Zaghi put out a protocol for image capture, and that can be referenced. It's in the literature, but it's essentially, as I described, you want to make sure that that patient takes a deep breath, is in their natural posture, walks towards the machine. And I think it's important to remember that the CBCT is a measure, it's a tool. It just might not be the most accurate method to hang our hat on and measure treatment success, okay? So this brings me to my recent publication. And in this publication, I did a retrospective study of symptomatic TMD patients. All of these patients were diagnosed with functional ankyglossia and low tongue posture and lateral thrust, and they all had documented forward head posture. So with this group of patients, we treated them and assessed different metrics pre-treatment and post-treatment. So I'm going to go into this a little bit. I had really strict diagnostic criteria for this study. I wanted to make sure that we didn't have outside factors that were contributing to some of the changes we were seeing. So because of the strict diagnostic criteria, the study wasn't as large as I would have hoped it to be. So there were 32 female patients included in the study. The reason I chose just female patients is because I suspected that there may be a change in hyoid bone position. And in my research, there is some research indicating that hyoid bone anatomy is a little bit different for males versus females. So I made the decision to only study female patients. And honestly, that's who I had the most of in my practice. What I also wanted to do is to have documented methods for symptom resolution. So on all of my patients in their intake, we have a 51 symptom checklist, and I also have them take the HIT6, which is the headache impact test. And so we administered those checklists and those screening tools at the start of treatment and then again at the end of treatment to have an objective measurement that these patients got better with treatment. The other thing we did is to include these patients in the study. We also performed the functional classification of ankyloglossia based on TRMR. So again, this is the ratio that Dr. Zaghi put out. So we did TRMR tip, TRMR LPS, and all of the patients in the study had a TRMR tip of 3 or more and a TRMR LPS of 3 or more. So it'd be a 3 or a 4. And I also performed the floor of mouth hold maneuver on these patients, and all of them had a restrictive floor of mouth hold. So that was inclusion into the study. There's one more factor I had to screen for, and so we're going to spend a little bit of time talking about this, and it has to do with occlusion and full body posture, right? So if our occlusion is off, our shoulder height can be off, our hip height can be off all the way down. Vice versa, if we have one foot shorter than another, the opposite can happen, right? And so if we have clinically one leg shorter than another, our shoulders can be off, our occlusion can be off. If I'm going to be studying forward head posture and improvements in forward head posture, I want to make sure that all of the patients in my study have what's called a descending syndrome, not an ascending syndrome, right? So there's a really easy way to assess for this. There was a study published by Hobson and Esser where they used an aqualizer splint to screen for ascending issues and descending issues. So some of you might be familiar with the aqualizer. It has these fluid-filled pads, and through the principle of Pascal's law, that fluid can move back and forth. So when you insert the aqualizer in between the teeth, we can balance out occlusion. And so when we bite down into the aqualizer and that fluid is distributed, we can then have the patients kind of move around, walk up and down stairs. And if it is a descending issue, meaning that the occlusion is what was causing the shoulders and pelvis to be not level, once we put the aqualizer in and have them move around, the shoulder height and pelvis height evens out. So therefore, we know we have a descending issue. In those patients where we walked around, we put the aqualizer in and we let them move around, and that pelvis height still was canted. Those patients were excluded from the study, and those patients were sent to body workers right away to assess for a leg length discrepancy. So this is just a little tidbit for your own practice. You can very easily screen for these types of issues and know when you need to get your patients over to a body worker to screen for a leg issue as well. So treatment protocol. So what did I do to treat these patients? So these patients were diagnosed with temporomandibular dysfunction. They had pain symptoms and headache symptoms. They were diagnosed with ankyloglossia and lateral tongue thrust. So what is my treatment protocol? In my office, the treatment protocol is myofunctional therapy, functional frenectomy. I do use a CO2 laser and I do suture, and then neuromuscular orthotics. So for me, the way I treat TMD is I use a neuromuscular approach by where I use a TENS unit to get the musculature relaxed. I have biometric equipment where I can measure where the jaw is in space. I can measure muscle activity, and I also refer to the CBCT and I look to see where I need to position that jaw joint to decompress, and then I make them a removable orthotic that they wear on the lower jaw. That works really well in practice for me. I'm not going to get too much into that protocol because that is a whole course in and of itself. But treatment protocol for all 32 patients were these 3 things. We made the neuromuscular orthotic and started myofunctional therapy all at the same time. The way we assessed whether our myofunctional therapy and functional frenectomy technique were effective is through the quick tongue tie assessment tool. So all of our patients have a measurement taken at the start of myofunctional therapy treatment, so at the very first appointment, and we take a picture of that assessment, and we do that with the tip of the tongue, so TRMR tip, and then we do that again with LPS. I've only demonstrated here the TRMR tip measurement. And so we take that measurement at the start of treatment. We take that measurement again after 4 sessions of myofunctional therapy. And then after 4 sessions of myofunctional therapy is when the release is performed in our office. And then we take that measurement again at the very end of treatment. So the protocol in our office for all of these patients, in order to keep things consistent, they had 4 sessions of myofunctional therapy. They had the functional frenectomy that was done by me. The myofunctional therapy was done by 2 separate providers, but same protocol. Following the release, they had 4 more sessions of myofunctional therapy, and then we reassessed. All of these patients as well, just as an aside, I did use the CO2 laser. I did place silk sutures. I prefer silk over the chromic gut and dissolvable. And then I do use periacral glue so I can space those sutures apart. So my protocol for neuromuscular orthotic, again, I'm not going to go too much into this, but this is what the neuromuscular orthotic looks like. So I use an anatomical orthotic, meaning that when we look down from the occlusal, it's shaped like teeth, so it doesn't feel as foreign to the tongue, and it's also not quite as bulky as some other devices out there. And my goal is to get this jaw joint decompressed and also get the muscles nice and happy. So this is just a recording of muscles of mastication and their activity. We want to see lower activity level, not higher activity level. And then after we relax the muscles and have the occlusion balanced out, we should see lower muscle activity. So again, it's measured rather than a guess in our practice. Usually with the neuromuscular orthotic, my rule of thumb is that the patient is in that device for 4 months symptom-free. So some patients, it takes a little bit longer to get there. So some patients might be in that orthotic for 4 months before we determine a second phase and how to stabilize them. Others, it might be 6 months. Others, it might be 9 months. For the purpose of this study, these patients were in the orthotic for a minimum of 4 months. So how do we evaluate pre-treatment versus post-treatment? So we look at a couple of things. First off, we looked at CBCT. So on each of these patients, they had a pre-treatment CBCT taken and a post-treatment CBCT taken. We had 2 separate post-treatment CBCTs done. One with the orthotic in, one with the orthotic out in their natural occlusion. So that gave us the ability to see what happens to posture and what happens to the airway with just myofunctional therapy and release as the treatment provided, and then with the added benefit of having the bite stabilized and the occlusion and jaw joint decompressed. So it was really helpful to have all 3 of those images. On the CBCT, I looked at several things. So I'm going to skip a slide for a minute. On the CBCT, I did the traditional airway analysis, right? So I looked at airway volume, I looked at minimal cross-section airway, and I also measured lateral width of the airway. This is probably a whole additional lecture. There is a muscle called the stylopharyngeus muscle, which is the only muscle that impacts lateral dimension of the airway. And so I wanted to see what happened laterally with these patients and if we were impacting that stylopharyngeus muscle with our treatments. Bottom line, we really weren't, but I wanted to measure that. The other analysis I did on the CBCT was a CBCT landmark analysis, and this took a little bit of time, but I wanted to see what was happening with this hyoid bone. It was my prediction that when we allowed the tongue to fit up against the palate and we freed up those restrictions and we allowed those suprahyoid muscles to function in their normal position, that we'd actually get a hyoid position change. And so I measured distance, anatomical distances from the hyoid bone. So we did this pre-treatment and post-treatment. So we measured from the hyoid bone to posterior nasal spine. We measured from the hyoid bone to a reference point on the mandible, from the hyoid bone to a reference point on C3. And then we measured from the hyoid bone all the way up to sella turcica. There's a vertical line here and a horizontal line here. And so then we measured that distance from those lines from sella turcica. So we did that pre-treatment, post-treatment. Okay, and then the other analysis we did was just a lateral photo analysis. I don't know if any of you use Posture Screen mobile app, but it is an incredible app. We have it on an iPad at our office, and you can take lateral photos and front-facing photos of your patients, and it does calculations for you. So this example is actually my daughter. My patient group was all adult patients, but she let me use her as a little model for Posture Screen Mobile. And you're able to take the lateral photo. If you already have lateral photos, you can upload that into Posture Screen Mobile app. And I am not a rep for Posture Screen Mobile. I make no money on this. I just found it a really great tool. And so once you have these photos, you go ahead and you mark landmarks on there, and it tells you which landmarks to click, and then it does an analysis for you, and it tells you about effective head weight. It tells you about the shifts from central. So it's a pretty cool application. So we did this on all of our patients pre-treatment and post-treatment. So when we were comparing data, we had data to look at symptoms. So looking at patient report of symptoms pre and post-treatment. So that was to prove if our treatment was effective in treating symptoms. We also had data to look at tongue posture. So we used that quick tongue tie assessment tool. And so we were able to prove that pre-treatment and post-treatment, we have gained more mobility for the tongue. And then we also have data to look at posture photos, so we can see and measure from a lateral posture perspective what's happening with the head. And then we can back that up additionally with looking at CBCT data. So when we look at pre-treatment, post-treatment, we had a lot of really cool things that came about. First off, we were able to show that our symptom checklist score changed dramatically. So we had a pre-treatment score of 14.9 all the way down to 7.1. Same thing with the HIT6. We had a pre-treatment HIT6 of 52.5 down to 44.6. So I did not do the biostatistics on this. I relied on a really amazing colleague, John Radke, and he did all of the statistics. And we found a statistical decrease in our pain scores, which was really great. It means our patients were feeling better. So we hear that our patients are feeling better. Now we can prove that from a statistical standpoint, that certainly did happen. We also looked at the posture for our patients. And so again, with this lateral photo analysis, we were able to see that forward head posture improved by 24%. So again, we did the Wilcox sign rank test, and the p-values showed a statistical change and improvement in forward head posture, both in head shift forward. Okay, so that'd be head shift forward and then head shift off vertical. And so that is an angular measurement in degrees. And then the other thing we found was that we did get a statistical improvement in tongue range of motion, which was great. I mean, that just proves that our treatment protocol for addressing the ankle glossia with myofunctional therapy and frenectomy was effective. So on to the landmark analysis, right? Because we know based on our results, pre-treatment, post-treatment, that our patients got better, they felt better, and the symptom checklists showed that improvement. We know that our treatment protocol of myofunctional therapy and frenectomy was effective. Our patients gained range of motion, and we were able to prove that with the quick tongue tie assessment, which is really important. And we also know that the lateral posture photos showed an improvement, okay? So they started out with more head extension, and as we looked at the pre-treatment and post-treatment side profile photos, they ended up with more flexion, they uprighted. But what was happening anatomically inside the mouth and anatomically with the neck? So analyzing this data was really interesting because we had all of these different landmarks to look at. And again, I thought what we were going to find is that we were going to get a change in hyoid bone position, which was going to impact our head posture. And what I found was it seems as if the hyoid bone didn't change at all. The hyoid bone stayed in the same position and everything else rotated around it. So why did I deduce that from the findings? When I looked at the hyoid bone, the distance from the hyoid bone to the epiglottis base did not have a statistical change pre and post treatment. Also, the distance from the hyoid bone, okay, up to posterior nasal spine, that did not change. Okay, so that's telling me the hyoid bone didn't move vertically up or down because these landmarks didn't change position, right? And so there was no change in those dimensions for the hyoid bone. Where we did have change is from the hyoid bone to the chin, okay, that decreased. We had a change in the chin to C3, that decreased. And interestingly, the hyoid bone up to this horizontal line up here based off of sella turcica, that increased, okay? So that tells me that this distance of the skull got taller, right? So as I'm looking at all of this, the evidence is supporting that we had a reduction in forward head posture due to cranial flexion, okay? Meaning that the head rotated up and back around, which is really, really cool. I wish in retrospect I would have measured some of these angular measurements, but I did not do that. I measured anatomical distance. So that would be something that we could do as a further study, is measure some different metrics. The other thing that was really interesting is that we found that there was a statistical improvement when we looked at myofunctional therapy and frenectomy alone. But when we added the orthotic in, which decompressed the jaw joint and stabilized the occlusion, we had an additional improvement in head posture. So head posture improved with the airway improvement due to helping releasing the tethered oral tissues and getting the tongue up on the palate, right? So we improved airway, head posture improved. But when we also improved joint position, forward head posture improved again. So that was a really cool finding. Now we get to airway analysis, right? And this is what we're really interested in, because when we treat our adult patients and we treat them for the low tongue posture and tethered oral tissues, our main goal is to make that airway bigger, right? And so we want to be able to look at these x-rays and see a difference. And I saw no statistical change pre-treatment to post-treatment, right? And so at first I was really bummed out by this. Like, geez, I really wanted to prove to my patients that we made their airway bigger. But when we look at it, that's exactly what we did, right? Because we took these images in natural head position. So we had the patients take a deep breath. They're in their natural posture. They walk towards the CBCT machine, right? And that's where we snap the image. So the previous slide just showed we had a change in forward head posture, meaning that the first image taken, their head was more extended forward. The second image taken, we had improvement and their head was more extended back. And we had no change in airway volume. There was no statistical change. It didn't get worse. It didn't get better, but it didn't get worse. So inherently, that means the airway volume actually got bigger, right? Because if we have a more uprighted posture and the airway volume stays the same pre and post treatment, airway did improve. It got bigger. So that's something to just remember when you're treating these patients and you take a pre-treatment CBCT and you take a post-treatment CBCT. If that airway measurement, that minimal cross-section airway measurement doesn't change or even gets a little worse, it doesn't mean your treatment was flawed. It doesn't mean you didn't make a difference. It just means the head's in a different position and probably in a better position, right? And so you can use those lateral posture photos to be able to monitor that difference. That's the beauty of the Posture Screen app. You don't have to do all of those crazy measurements that I did for anatomical landmark analysis, right? You can do those posture photos. And if you see a statistical change in the head posture from those posture photos, and you see no change in airway volume pre and post treatment, you made the airway bigger. And so that was really cool. So clinical implications for practice. Why did I do all of this? Why does it matter? One of the things that can be really difficult for these patients is the interdisciplinary care. I totally believe in interdisciplinary treatment. I totally believe in working with body workers. We need to improve the forward head posture for these patients for them to fully get better and for the pain symptoms to decrease. But when do we integrate that interdisciplinary care? A lot of these patients come to us and they're really overwhelmed and we just want to start to get something done. And so the impact of this study is that we can start treating those patients from a craniofacial health standpoint and from an airway standpoint. Do the things that we can do to help them to feel better. We'll get an improvement in head posture. They'll start to feel better, and then we can have them work with a body worker and get the remainder of improvement. So it's important to note that I didn't find in this study that all of the patients improved to the point where they didn't need other body work. They did. Also, I think I didn't say earlier on, these patients didn't have any body work interventions during the time of the study. All the body work interventions happened after the post-treatment x-rays. So that's really important. I totally forgot to say that. So it's really important to note that yes, we still need that interdisciplinary care. We still need to work with our chiropractors and physical therapists, myofascial release therapists, super important. But we can make some measurable improvements right away and early on in treatment for these patients, get them out of that sympathetic overdrive and start to get them more into this rest and relax to where then when we integrate other providers, it becomes a little bit easier for the patient. They're more open to that and they're not trying to do so many things at once. The other thing that's really great is it does give us some validated tools to be able to measure success for our patients. So one of the things that we can utilize is that Posture Screen mobile app. It does work really, really nicely for a quick evaluation on head posture. We also know that we can utilize metrics with measuring anatomical distance to hyoid bone, although that is a bit laborious. And then it just gives us information and confidence that if we're using that metric of minimal cross-section airway and airway volume and lateral dimension, and we don't see any changes pre and post treatment, it doesn't mean we haven't done anything, and it doesn't mean there isn't improvement, right? If head posture changes and the volume doesn't, in essence, we've still made airway bigger, which is really cool. So treatment recommendations, I think one of the things that is really important to remember, and one thing that weirdly was driven home for me, is that it's important to have a protocol for gathering information for these patients. So because I did a retrospective study, I was really fortunate that all the information was already there. We had CBCTs on every single patient, and the CBCTs were taken by providers that were very well trained in that NHP position. So super important. We also had data on TR-MR tip and TR-MR LPS on every single patient. We had data on the quick tongue tie assessment on every single patient. So our protocols had been set in place, and we had all this information. So it made it really easy for us to go back, gather this information, and look at what is happening. So if that's something that isn't super consistent in your office, that would be something to look at, is what is our protocol for gathering records? In our office, our records gathering protocol happens pre-treatment, and then everything gathered pre-treatment happens post-treatment without an orthotic and post-treatment with an orthotic. So it made conducting this study a little bit easier, which was great. Also important is just to note that interdisciplinary treatment is super important. You know, in our office, I'm really lucky because we have a myofunctional therapist working with us. And so working with that myofunctional therapist is easy for me to do. But coordinating the interdisciplinary care is so key. We cannot treat airway and TMJ occlusion without impacting cervical posture. They are connected. And we can't treat those things without working with other providers. So although we can make differences just as a dentist and as a myofunctional therapist, we still need help from others in the field. We talked a little bit about some of the limitations from the study already. The biggest limitation was the sample size. So I really would have liked to have more individuals included in the study. I'm currently working to try to gather more data and publish a subsequent study. I had a really broad age range, like 25 to 70 years old is a really broad age range. I needed to have that age range just to have the study size be impactful enough. And then I think I really would include males in my study next time. This time around, I only did females, again because I wasn't quite sure if we'd see a hyoid bone change, and the hyoid bone is a little bit different males to females. And then this is just a photo of different ways to assess head posture on lateral ceph or CBCT. We can do the CPL HOR angular measurements, which next time I think I would absolutely do, versus anatomical landmark distance. Again, I just wasn't quite sure what I was going to find. So takeaways, why is this important? Forward head posture is an end stream compensation, right? Usually starts with an airway consideration, which then allows us to bring our head forward so we can breathe better, which is amazing. But that compensation then causes downstream effects, causes the mandible to get pulled back and upward, right? So posterior, superiorly. So it can cause TMJ issues. It causes pull on cervical muscles. It causes a lot of additional pressure on the cervical spine due to the head being off of the center of gravity, right? And so many times we're dealing and treating these end stage compensatory adaptations, and really from the research, we should be starting at the root cause. Let's address the airway. Let's address the tethered oral tissues. Let's address the jaw joint. Let's get those corrected first, then see what happens to the posture, because it will improve. Then treat the compensatory adaptations, and we're going to have much more success. So I just put a few QR codes on here for you guys. First QR code is my research publication. If you want to read it in more detail, that will take you to that link. The second QR code is just the QR code for the organization that I'm really involved in, International College of Craniomandibular Orthopedics. Again, I have disclosure. I don't make any money from MICCMO. I'm just really passionate. And if you are wanting to get into treating TMD and you're looking for a place that will support you in that, ICCMO is a great organization. And then this last QR code is just my contact information. If you have any questions, feel free to reach out to me. And that has all my information on it.
Thank you, thank you, thank you. What a wonderful presentation and much needed for us to be talking about this. Alex is saying, love your presentation to show your research publication and the treatment modalities you use to support your patients. I believe the neuromuscular component is not as well known and very important component. Thank you. I'm going to ask some questions that maybe you have already shared.
Okay.
Presentation, but it's just for us to do cuts for meals and get people interested to come watch the rest. So here we go.
All right.
What is one thing most airway dentists are missing in your opinion? Because not everybody looks at as many things that you're looking at right now. And since you do have this umbrella knowledge of several different things in airway, what is the one thing that most airway professionals are missing?
I think the thing that a lot of airway professionals are missing is the compensations that the mandible makes when we have an airway health issue. So I think as airway practitioners, we're really well trained in tethered oral tissues. Like, that's part of it. We know that we need expansion to be able to have proper airway health. We're really good at that. What we're not so great at is zooming in and looking at what's happening within the jaw joint and with the muscles of mastication. And we know when we have airway issues and we have this forward head posture compensation, we automatically have a mandibular compensation, and the condyle is pushed posterior and superior in the fossa. And so we just miss that.
Amazing. How are you guys making sure that whenever you're taking a CBCT on a patient and then retaking it, that you have the patient position as close to what it was the first time as possible? Do you have a protocol? Do you have a way that you guys check that?
We do. So the protocol we use was set forth by Dr. Zaghi. There is the research publication that I shared on my PowerPoint presentation has the name of that study, but in there he details out his protocol by where you have the patient out of the machine first, right? And we have the patient take a deep breath, shake it out, and just stand in their comfortable position. And then they walk to the machine. So we bring the patient to the machine before, and then we bring the machine to the patient, right? So we walk the patient in. Once they're in the machine, we don't have the patient, oh, move your head forward and do this and do this. No, right?
Mm-hmm.
They walk into it, and then we bring the rest to them. Okay,
Amazing.
so that's best we can, right? Now, sometimes we take the image and there's something within the anatomy that's out of our view, and we're like, ooh, okay, we have to retake this, and right, but it generally works really well.
Perfect. Where should we start with a patient that has acute TMJ pain?
So that's a really detailed diagnosis.
Yeah.
Always start with a really detailed diagnosis, right?
Amazing.
So I'm looking at not only range of motion, jaw opening, jaw closing. I measure intermolar distance. I look at facial asymmetries. I look at swallowing patterns. I look for tethered oral tissues. I have them stand up and I do a posture analysis and look at hip heights. I look for forward head posture. So it's super comprehensive. I don't look at any one thing. Honestly, I do an orthodontic evaluation and a tethered oral tissue evaluation and a posture evaluation, all of those things, because
Amazing.
you have to determine the root cause. If you don't have the correct diagnosis, you'll only have partial improvement, right? And
That's the best answer I've ever heard.
it is.
You start with the assessment because a lot of people would say a treatment. That's great.
Yeah, you have to start with assessment. I honestly, I don't give a treatment plan until 3 appointments in.
I love that.
So we do a patient interview. We start with assessment. We really dig in to get the right diagnosis. And so from that assessment, then we move to the records, right? So our image gathering protocol, our photos. Then I meet up with the patient. That's when we decide a treatment plan. So
Perfect. Have you ever worked with any professionals who do hyoid releases?
I haven't, I've read about it and it
Uh-huh.
sounds super interesting.
Yes, we had someone. She's done a talk for us on Clubhouse. So for anybody who's an Airway Circle member, you guys can go back to the Clubhouse days. And it was the fascia team. We had a whole talk on fascia back in the day. We were talking about fascia, y'all. I think it was 2020, 2021. But she was wonderful, and I just met her in Australia. I'm gonna have to pull her up again for you guys to look at her stuff. But she talked a lot about this hyoid release. I thought was so cool.
That sounds really cool. And that's one of the things that surprised me about my research is I really truly expected to find a change in hyoid bone position, right?
Hmm. That was very interesting.
And there was no change. And so that was fascinating to me. And it makes me wonder if there was fascia injury in that area that's why we don't see a hyoid bone change. I mean, it's really possible, right? Because any compensatory adaptations can cause injury in the fascia,
Hmm.
right? So that is fascinating to me. And I definitely want to look more into that. I would love to have her name. That's fascinating.
Yes, yes, I'll send it to you. At what point do you usually recommend myofunctional therapy?
Right away. Right away. Um,
Good.
I would say with my adult patient population, both that see me for chronic pain, TMD issues, and airway issues, and orthodontic kiddos. So like 50% of my practice is kids and 50% is adults, right? I'm trying to catch them as early as I can. But for both patient groups, I find that the reason they have the adaptations they do is because of the tongue, right? I mean, so rarely do I find that there isn't a restriction. And
Mm-hmm.
and I know there's information out there, oh, it's overly diagnosed. Da, da, da.
Yeah,
But when I hold down the floor of the mouth and they can't move their tongue, like to me, that's not overly diagnosed.
exactly.
Right?
Just people, yeah.
So right
Yeah.
away, and there's a caveat to that, right? So
Mm-hmm.
in my practice, if they have a really narrow intermolar distance, so to me, 33, 34 millimeters under that, then I will expand first. That would be the only time I wouldn't go in there and start the myofunctional therapy and release roots. Because
Mm-hmm.
if they can't get their tongue to their palate, we actually can do more damage than good.
Mm-hmm. I started showing my patients the way that I look. I actually look at the CBCT image to see if there's room intraorally for the tongue. And I am actually more worried about the AP deficiency that I am
Yeah,
transverse.
yeah, yeah.
I
And
I was a 30 molar to molar when I had mine released, but I did it on purpose because I already had my MARPI scheduled for a month out. So
okay.
like I want to see what this is going to do. And of course I was willing to go through the yes, but we have a little protocol of things that we have to look for, including the CBCT to see if that's a patient that we would recommend, even though they're transverse deficient. But it's so interesting to see some of these cases.
Yeah, and that
Yeah.
and you hit Renata on the key thing there, right? I mean, you can have the transverse deficiency, um, And there are some cases where that transverse deficiency is there, and I will elect to start the OMT and release if they have a ton of AP, right? Based off of CBCT, if they have, you know, a ton of AP room,
Yeah.
then
And
I
what
kind
does
of
the
will
tongue
start
look
it.
like? If the tongue is huge, then there's just no
There's
way
no.
that'll be too dangerous. But yes, awesome.
Yeah.
What advancements or research in airway health and neuromuscular orthodontics are you most excited about?
Oh boy. Um, I think the thing that is really exciting to me is connecting the dots between tethered oral tissues and all of these compensatory adaptations, right? That, we know that form follows function, right? And so if the tongue isn't functioning properly, things aren't going to develop properly.
Hmm.
So the form, the structure follows that function. And that's really groundbreaking and cool because if we can catch these kiddos really early on, I don't have these patients in my practice that I have to then
Hmm.
on the back end treat orofacial pain, right? And so I think that's really the neatest thing is making these connections to say, hey, how can we help these patients earlier and earlier so that we don't have these issues?
Amazing. How soon after, or how many years after you were doing dentistry that you started introducing these airway things into your practice? Was that difficult? How did you make the transition and start talking to your patients about these new things that maybe they were not aware of?
You know, I think I started introducing the airway concepts 2013, 14, and I started practicing orthodontics in 2008. So probably like 6, 7 years into practice. And the reason I really went down this airway rabbit hole is because I noticed some of my orthodontic patients got better really fast, right? And
Hmm.
some of them I'm like beating my head against the wall. I'm like, why won't their bite open up? Why won't they expand like they should, right? Those were the cases they had severe issues with ankyglossia, right? And a
Hmm.
lateral tongue thrust. And so the muscle's always going to win. Um, so I don't think it was really difficult for me to integrate it into my practice because it made sense to me. And so I just jumped in. I think the more difficult part, honestly, was getting my team in place, right? And getting everybody else trained so that we had a good protocol in place. That was the trickiest, is just getting everyone on board.
Amazing. Well, thank you so much for this amazing hour that you spent with us. Alex, I do see some questions on here. Is there anything that I haven't answered, that I haven't asked? Please just let me know. Otherwise, this is going into our membership portal right away. So if you're a member, you're going to get to watch this right now. Otherwise, you're going to have to wait for the Thursday Night Live. However, this was wonderful. Thank you so much, Dr.
Of
Jennifer, for
course.
your time with us. Anything else you would like to share before we go? How can patients find you? Do you have an Instagram account?
I have a Facebook account. I think the office has it,
Girl,
but
come
I
on.
am not as good with social media as you are. I'm working on it. My 16-year-old is like helping me into that world for sure.
Yay!
So my practice is 201 Waterfront Dental. So that is it, and Bite Aligned. So that is out there. We have Facebook, and I think we have Instagram. Also, the QR code that I shared that has all of my contact information, my email, and whatnot. So feel free to contact me.
All right. Thank you so much. Everybody have a wonderful night. I'm going to say night. Everybody have a wonderful night. Thank y'all for being here. Thanks for everybody who was here live. We love you. Have a wonderful weekend.
Thank you for
Bye.
having me.
See you later. Thank you.